My name is Calvin.
And my name's Kylie.
And I'm the father.
I'm the mom of Kendall.
When she was almost 12 months, doctors kind of noticed that she wasn't really catching up in terms of her development. And then also at 12 months, she got sick and she had a seizure. So that's when we found out that she had epilepsy, but they didn't know why.
We only see doctors maybe once a year for our older daughter. But with Kendall,
it's in the beginning, it was almost twice every month, different doctors and different therapists until they finally found out that she had the GRIN 2D mutation. We finally knew what's wrong with her. But at the same time, it was devastating because when we looked it up, it's very rare and there were no cures for it, barely any research. We were kind of a mess when the doctor tells you that your child is not going to be normal. That was very tough. That devastated us. And it took us a while to kind of accept it was going to be a totally different life for her and for us. We felt kind of alone the first couple of months until we started reaching out to support groups. And that's when we saw that there's a whole community and a lot of people that have lived through what we're living right now.
So for Kendall, she has mixed muscle tone, epilepsies. Also, she's not walking yet, but since last year, she was able to sit up, so that was a huge improvement. And she's not talking yet. She also had CVI, cortical vision impairment, where she couldn't really see well, but she's been doing vision therapy. And I felt like there's that moment where she was looking into my eye, and it was really rare. And when I saw that, I was so happy. It's like something that you think about.
You take for granted.
Yeah, take it for granted. But when she looked into my eye for that maybe a couple seconds, then I know that she knows who I am.
I think now there's been a lot more research going on in the scientific world. And in our world, she has been showing signs of improvement. So that gives us a lot of hope. Hopefully there's a cure for this GRIN disorder that can help her, get just even close to be self-sufficient. That would be our biggest hope.
Welcome to GRIN Mini Conference. Thank you for joining us. I'm Denise Renner, and this is Brett. Brett is 7 years old, and he has a variant in his GRIN 1 gene. I'm the president of CureGRIN, and we are 2/3 way through our GRIN Disorder Awareness Month. This is our second annual GRIN Disorder Awareness Month, where we are collaborating with all the other foundations and groups to share our stories, to share facts about GRIN disorder and to spread awareness. So thank you for everybody who has shared our posts, liked our posts, shared it with your friends, and we truly appreciate it. We have a really exciting agenda. We have Keith MacArthur, CEO of CureGRIN. He's going to share the results of the recent GRIN family survey. And then we're going to open it up to our amazing GRIN researchers for an Ask Me Anything Q&A. And hopefully you will stick around for our happy hour right after this. I'm going to post the link in the chat in case you haven't registered. We would like for you to register if you want to join, so we make sure we have enough spots for everybody. Again, welcome. Thank you so much for joining us. It's so great to see so many people, so many faces, so many families. So with that, I will hand it over to you, Keith.
Thanks, Denise. Just one thing to mention to you, Denise, I went to register this morning, and in order to register, it wanted me to actually join the session. So I worry if people join now, it might take over their microphones, the other program, and they won't, or their cameras.
You mean for the happy hour?
Yeah. So I don't know if it's because I waited till today.
So wait till this is over, and I'll post the link like right before this ends.
Okay. Okay, so good to see so many people joining us. Thank you for being here today. I'm going to start for a minute to give everybody an update on where we're at with building a research and science plan for CureGRIN. And a big part of that is the family survey that we did, and we were so grateful for the response. So I'm going to share the results from that survey with you today. So first, just a quick overview of what we're working on. Basically, we started this program with a research audit that we started last year. We've done surveys of both parents and researchers and doctors. We're about to start the next phase, which is to create a list of research gaps and priorities. So basically, we want to know all of the key questions that we need to get asked in order to get to the right cures and treatments for people around the world with GRIN disorder. We're going to share that early draft, get feedback from parents and the research community, and we're planning to present that final document on Saturday, May the 1st. So we're going to send out another invite for another meetup on that day. And that's where, as long as we can move quickly in this next phase, that's where we're hoping to share the results. And that was going to be when we were originally planning to meet in Boston for, I guess, the second date we'd picked for the GRIN scientific conference. But we've moved that now a full year into spring of 2022. And then once that's finalized, we're going to go out and recruit the best researcher for each of the priorities we've identified. So here's the results from the GRIN family survey. So we have, our goal was to get 175 people to fill in the survey. We were really happy with the results. 197 families filled it in. So we got more GRIN 1 and more GRIN 2B than we were expecting. GRIN 2D is a small population, so we thought we might only get about 5, but we got 10 there. GRIN 2A, we didn't quite meet our goal. We were aiming for 50, we got 36. We got responses from all over the world, 5 different continents. And you know, one of the things that I'm pleased at when I look at this chart is that the responses from North America are actually less than half of the total responses. So we have, I think, more from Europe than we have from North America, and then we have handfuls from Australia, South America, and Asia as well. So a good representation from around the world. We asked the birth year of the patients, and this is significant that, you know, among the people who filled in the survey, among the GRIN population that we know, about 93% of the population is under 20. And we think the main reason of that is just that these tests, the the sequencing tests where people get the results, just are primarily done right now on people under 10 or under 20. And so, you know, there's this huge population of people 20 and up that just have never had the chance to get a diagnosis for their disorder. And we suspect that, you know, that there's a much bigger population of GRIN than we know about. But we expect the youngest ages to keep growing and more people to be diagnosed as they're young every year. But we'd love over time to also see more of those older people diagnosed so that we can help them as well. We asked the sex of the patients, and there were 61% that were women. So we thought, you know, a lot of them are obviously under 20. Girls or women, and so that could be significant. It could be a function of sample size, but we also, you know, broke it down here by gene. I didn't include GRIN 2D because it's such a small sample. But what's interesting here is that within the GRIN 2B community, the breakdown is even higher. 2/3 of the respondents from that community, or nearly 2/3, the patient is a female. So, you know, this is something that is probably worth looking into. I don't know. I know that, you know, GRIN 2B Foundation has a list of its patients. I know that there's been, you know, patients in the database. So a good next step would just be for us to see in those other groups whether the female outnumber the male, and it could mean something like, yeah, I don't know. We have to find out if it's significant or not. We asked all of you what the what symptoms your children have, and so the column on the left is for all GRIN, so all 197 people, or families that responded to this study. And so intellectual disability is the #1 symptom. 91% of people who filled in the survey said that their child had intellectual disability. There were also a couple of people who filled in the survey themselves, so not just their children. Speech, communication issues was about 80%, low muscle tone, 72, then sleep, mood, epilepsy, mobility. You can see the list there. We also, on the other ones, we have this broken down by the different genes. And so I've included everything in the right there where over a symptom occurred in over 50% of the population. So you can see that the numbers do vary a little bit by gene. So for example, GRIN 2A has the highest, well, other than GRIN 2D, which is a small sample size, GRIN 2A has quite a high number for epilepsy. So it's 69 compared with, I think for GRIN 2B, it's around just over a third of the GRIN 2B population. So it's not on that list. So I would say that across the genes, there are patients that have all of the symptoms, but the symptoms can be more or less common based on which gene people are talking about. We also asked people to fill in other symptoms that the children had, so ones that we didn't include on the list. And so here are some of the key ones that weren't included. So movement disorder was a pretty big one, and that's probably one that should have been included in our study, but lots of parents mentioning dystonia, stereotypic or hyperkinetic movements. Autism, sensory processing disorder, which is often connected to autism, anxiety and panic attacks, and then gross motor and fine motor challenges. So we mentioned mobility in particular, but I think some people may have included these gross motor issues in there, but maybe not for kids who can walk. So those are some of the key ones. And there's dozens of others that people said, many people reporting, just a single family reporting a symptom. So we'll take a look at those as we plan out our scientific plan as well. And then we asked what symptoms, So here's what I wanted to share next. In addition to the 197 families who filled it out from GRIN, we also asked GRIA families. So GRIN GRIN genes affect the NMDA receptor, and GRIA genes affect the AMPA receptor. These two receptors operate very similarly in the brain, and they actually can influence each other. So we're starting to work closely with the GRIA community because we know that a lot of the researchers from both communities are the same, and we believe that we know that the symptoms are the same, and we believe that the path to a cure could be the same or similar for both. So I just thought it would be interesting here to kind of highlight the GRIN beside the GRIA. The top issues are very much the same in both. So the percentages are a little bit different, but overall, many of the same symptoms at the top of the list and the bottom of the list. We also asked you, what's the most important symptom? So if you had to pick one that you wanted us and our research community to focus on in terms of finding cures and treatments, what would it be? So the #1 that people identified was intellectual disability, followed by epilepsy, speech, mood and behavior issues, and neurostorms. So those were the top 5. And you can see over on the right, again, we've listed the top 3 by each of the genes. And GRIN 2B, as I mentioned before, only about 1/3 of their population has epilepsy. So epilepsy doesn't show up in their top 3. But for all the rest, epilepsy and ID are the #1 and 2 top concerns for people. And then some of the other ones that we see there are mood and behavior, neurostorms, and mobility challenges. So following up from the survey, we conducted focus groups on 8 different focus groups. So one for each of the genes, one for each of these 4 genes, plus one for AMPA families or GRIA families with disorders in the AMPA receptor. And then we also conducted 3 other focus groups. One where we brought together families who had indicated intellectual disability and neurostorms as their top priority. One for families who had indicated epilepsy as their top priority. and one for families who had marked down either intellectual disability or speech. Based on some of the survey responses, we had a hunch that those two groups were connected, and that was certainly validated in the focus groups. Even a lot of the families who had put intellectual disability down as their top choice, many of them said the key issue when they think about intellectual disability is their child's ability to communicate with them and express their wants and needs. And then in the group where we had people with mood, behavior, and neurostorms, there was a lot of overlap here. A lot of families saying, I don't know which one my child has. Sometimes I think they have both maybe, but I can't tell which one is which when they have these episodes, or maybe they can tell, but there's certainly a lot of overlap there. So we grouped those together, and just to kind of give you a breakdown of the top three groupings by gene, you can see that intellectual disability and communication is really big for GRIN 2B in particular, not so big for GRIN 2A, but then for GRIN 2A, epilepsy is their top issue. And so, a big part of this, how it breaks down is, I would say that across the board, if their child had epilepsy, it's typically the number one focus, unless they have medication that's helping with epilepsy. But because epilepsy, I wonder if there's a way to mute that. Okay. Yeah, because epilepsy is not as common, maybe in many of the other genes, it doesn't show up quite as highly. Okay. We also did a survey of researchers and doctors. And so we asked how much, somebody has their mic on, and I don't know if everybody else is hearing it, but I hear a big echo. Denise, I don't know if I can mute.
Yeah, I'm looking. It might be Claudia if I can't mute you for some reason, but
okay.
I think we're good now.
Okay. Sorry, I gotta fix this. I was trying to go backwards and I was going forward. Yeah, so the first question, or another question that we asked researchers, is how much time they spend on working on NMDA receptors, GRIN genes, and GRIN disorder. And we only had about 30 responses from these researchers and doctors, and quite a few. So they spend over half of their time doing it, which is a pretty good number. There's at least 12 researchers that are spending a lot of time on GRIN disorder research. So that's great for where we're at in our community. We asked them a question that we didn't ask to parents, but when we think about treatments and cures, we sort of think of two broad areas that we could focus on. And one is traditional medicine. So things like, scientists talk about them as typically as small molecules, but it's what you might think of as a drug. So it's often a pill that will change the chemistry in your brain or other parts of your body. The other is DNA or RNA therapies that will actually change the way that your cells are being built. It'll change the code for those cells and how many of them get built. So we asked researchers, which of these do you think are the most important for us to prioritize? The vast majority said we should prioritize them both about the same, but there were a few more who mentioned DNA and RNA medicines than who mentioned traditional medicines. And then here, we asked about cures versus treatments. This is a question we asked from both the families and the researchers. So basically, we wanted to know. We know that finding a cure is something that you think of as a real cure that would kind of maybe fix everything. That'll take a lot of time, but we could find treatments much sooner that would help with specific symptoms. So we asked which of these is more important. So you can see that among the family on the left and the researchers on the right, most said prioritize these about equally, but for both groups as well, more said to focus on the symptoms. So certainly, as we're building out our science and research plan, this is something that is going to help guide us. That really we need to balance both of these two both of these two things and be looking for what can help, working with researchers to identify what can help your kids now and what could help us to beat this disease over the medium or longer term. We also asked about whether we should prioritize disorders that could help as many people as possible, even if they take longer, or disorders that could help a smaller population that might come sooner. So here the families, about 50% of you said prioritize them both about equally, but there was a slightly higher number of family members who said prioritize the ones that can help everyone, even if they come longer. And then on the research side, even more of them said prioritize them equally. And there was a higher number that said prioritize the shorter term ones that could help a smaller group of people. And then the same list of symptoms that we asked families about, we also asked researchers, but we asked them a different question. We said, for all of these, how long, like how big a challenge is it going to be to find treatments or cures for these individual symptoms? Is this something that, you know, how much time and effort and resources and money is it going to take? And you know, the bad news here is that there's no easy fixes, right? There's nothing that is lower than a 5. And some of the things that are, well, I guess, the thing that we saw that was the most important for families, which is intellectual disability, is scientists believe it's going to be the hardest of them all. So I'm just going to look in the chat now and see if there were any questions. And if anyone else has any questions, you can add them here as well. So is someone asked, is mood based on a person with no medication, or is this based on a person who take meds? Many meds have an effect. The person's mood and behavior, and med cocktails just take it to a whole new level. Even if a side effect with medication doesn't list mood, we've had behavior issues as well. So yeah, I think we don't know how families filled this in. We basically just asked whether your child has a symptom and how important is it to you to fix it. But based on the focus groups, the people that we talked to in the focus groups, they were generally talking about something that happens with their children not related to medicine, and most of these families have tried medicines and they generally haven't helped or they haven't done enough. Oh, someone said if I use earbuds with mic, it'll get rid of the echo. So am I still echoing?
Nope, you're good. But there's some questions about people are asking to explain what you mean by the term neurostorms.
Okay, yeah. So great question. And this is something where we are going to be putting up a blog post explaining this on the CureGRIN website in the next little while. But this was something that first came up at our last GRIN conference, that when we were talking about episodes that children have that sort of erupt spontaneously, but are not seizures, that a lot of families report. We didn't really know what they were, but we had a couple of neurologists at the last, or neurologists and I guess neuroscientists at the last family meeting that were talking about this and mentioned neurostorms. So it's something we've looked into a lot. And one version of neurostorms is something that affects the sympathetic nervous system, and it can come on spontaneously, it can end spontaneously. And so typically, because it affects the sympathetic nervous system, it involves symptoms like pupils dilating, body temperature rising, heart rate rising, breathing faster, children sweating a lot, and they almost can seem like they're not present when they're going through one of these storms. So their nervous system basically just goes out of whack because of something that's happening in the child's brain. So that's sort of what we know so far. There may be other forms of neurostorms too, but essentially it's something that's happening in the brain that is not strictly behavior, but can lead to quite significant episodes that are very hard for a child to come out of. They are not captured on an EEG, no. So, there are families who have asked, who think their children have seizures because they have these episodes. And my son Bryson is an example where we've done several EEGs. Doctors have seen them and thought that they were seizures. They haven't been captured on an EEG. But because Bryson's pupils enlarge and he really gets sweaty during one, and they start suddenly and stop suddenly, and he gets hot, and just a number of these symptoms, we really suspect that it's neurostorm, and the meds that he's gone on, one med in particular, which is clonidine, has really helped him with that because it sort of capped the peak of these neurostorms. So he probably doesn't have as many, but certainly the ones that he does have are not near as significant as they used to be. Can I explain what is a panic attack for our GRIN kids? Yeah, I don't know if I can answer that. I think you're asking this because one of the write-in symptoms categories, we had panic attacks and anxiety. So I don't know. I don't know what the family had in mind, but this may be something that is more common, possibly with kids with higher, or I guess more moderate intellectual disability, but I don't really know, and it might be something that that the panel could answer. Any other questions before we turn it over to our Ask Me Anything panel? So someone's asked, are there supplements, vitamins, other that could improve brain functioning? And I think that's a good question as well to leave to the panel. I do know of some, but I think it would be good to hear, because we've got all these experts here. I think we should leave it to them. So I will stop the sharing and hand it over to Megan, who will take it from here with our researchers.
Hi, everyone. My name is Megan Collins. I'm the research coordinator for CureGRIN, and today we are joined by 4 fantastic researchers who are going to be answering your questions. So we received a lot of questions by email, and then you guys can feel free to keep adding questions in the chat, and we'll go till the end of the hour. So we'll go ahead and get started. So the first question that we have is related to the COVID vaccine, and is it safe for those with a GRIN diagnosis?
And would you like us to just jump in, or are you going to call on us?
And you might be the best person to answer this question.
Yes, Anne, you can start.
I'm Anne Paduri. I'm a pediatric neurologist and epilepsy genetics researcher at Boston Children's Hospital. And I'm very sorry we're not able to meet in person this year in Boston, but hopefully next year. The question is a really great one and very topical about the COVID vaccine. And I'll preface this by saying that this is not necessarily GRIN specific advice or GRIN specific recommendation, but I think that's going to be a recurring theme as we go through a lot of the conversation this hour, that we have a desire to do very gene specific and disease modifying treatment if we can. But a lot of what we're doing is managing symptoms, managing situations in a way that's not necessarily diagnosis specific or gene specific yet. So I'll start just by saying that, because I don't want us to have the sense that we're doing something different for GRIN 2A versus GRIN 2D, or even the GRINs versus the sodium channels and the potassium channels in terms of our general recommendations. So the short answer to the question is yes, it should be safe unless there's some contraindication. So there's some allergies that people might have that are listed that you shouldn't have a COVID vaccine if you're allergic to various things. But in general, as you know, I think all of us in the medical field feel very strongly about is the vaccines. Every treatment, every vaccine is going to have a potential risk, but we really feel like the risks are small compared to the potential benefits, and potentially really could be life-saving for a number of people, particularly with COVID, where the disease is anywhere from asymptomatic to horrible. and where we have our kids who really need to be in contact, not only with family members, teachers, therapists, and so on. We want to be able to have them back out in the community. So we're strongly recommending in our practice that children do get vaccinated when the time comes. I think the other side of that question is, when can we get vaccinated? You know, for the kids who are, at least in Massachusetts, and in the US, it depends from state to state, but in Massachusetts, you have to have 2 qualifying diagnoses to be able to be prioritized for vaccination, and you have to be over 16. We're hoping to move down to over 12 soon. So that can be, epilepsy as one diagnosis, but it also has to have other diagnoses along with it, such as moderate to severe asthma, or respiratory difficulty, and so on. So I have to say, I've been somewhat disappointed. A lot of my patients with genetic epilepsies have not yet qualified, even though I think they're very much in need. In fact, in more need than me. I've been able to do my clinic virtually since last March, literally to the month, and I've only gone in person for the couple of weeks when I've been on service, or there's been an extenuating circumstance. I think our patients need it actually more than those of us who are outpatient doctors, and so we need to lobby hard to promote that. So yes, I think it's safe, and I think we should all advocate for it happening as soon as possible for all of your children who have these GRIN disorders.
Perfect. Thank you, Dr. Paduri. So our next question was from the same individual, and they were asking, what's the best way to find medical professionals who may be knowledgeable about GRIN, whether that's primary care, neurologists, geneticists? They said that they particularly live in southeastern Pennsylvania.
I think that's a difficult question because there are not many clinical experts around that take care of more than one GRIN patients and that consider themselves as experts in the field. So I think looking for doctors in a country is already difficult. Maybe you should rather check for a continent or something like that. So there will be a few doctors in Northern America, there will be a few doctors in Europe, but I'm working with GRIN disorders for many years now, and I don't know many experts on GRIN disorders in all the European or the Middle European countries. I know a few, but in the end, I would say it's important to have a doctor that is aware of that it is a genetic disorder, and who is open to interact with GRIN experts in other countries. So it doesn't necessarily need to be an expert on particular GRIN 2A, GRIN 2B, or what other GRIN disorders.
Great, thanks, Dr. Lemke. So our next question is about GRIA disorder, and what are some ways that we can also incorporate GRIA research based on what we're doing with CureGRIN in terms of investigations that you guys might suggest for AMPA receptor?
So this is Catherine Roche, and I'm not going to have a good answer for that, but I'm quite curious to ask Keith about the GRIA disorders and the GRIN, and is there an effort to compile a database, and if the numbers are similar between AMPA and the GRIN disorders, or is it too early to know?
Are you asking in terms of the patient population?
Yeah, I'm just wondering, because you guys have done such a great job with the GRIN disorders as kind of making a community and trying to collect data and get numbers, and how far along is the AMPA, and are there similar numbers of patients, or it's just too early to tell because they haven't been as organized?
Yeah, Dr. Lemke may want to jump into, because I think they may be being captured in his and Dr. Benke's databases, but our sense is that the GRIA population is much smaller. Although there are 4 different GRIA genes, and we know of patients with all I guess variants in each of the 4 genes who have pathogenic or seem to be disease-causing variants. But we are working quite closely with them. We actually have a family with a GRIA mom who sits on our board meetings, and we are working really closely because we believe that so much of the research will be similar, and the path to cures may be similar.
I think in terms of the research community, there are a number of basic neuroscientists who do study AMPA receptors, and there's a lot of work that's done with mouse models, not necessarily of disease-causing pathogenic variants. That's probably pretty new. But I believe that the research around GRIA will be just as robust as around the GRIN disorders. And it's, I think, maybe going to be recruiting people to make those mice and start doing the same things we're doing with the GRIN variants in the AMPA receptor genes. But in terms of the interest in AMPA receptors and, you know, the basic neurobiology questions, I think that research is just as robust as it is for NMDA receptors.
Great, thank you so much. So our next question is about finding a cure. And so the question is phrased, previously it was said that a cure may be possible within 5 to 10 years. Is this time frame honestly still achievable? And when researchers say a cure, it will most likely be gene editing, correct? I know researchers are already using gene editing on mice. What is the next stage? Will it be a larger animal or more stages before we go to human trials?
I think that a cure in 5 years is quite unrealistic, and I think that you know, even 10 years would be quite surprising. So I think that first of all, we should push our horizon farther, because we don't have a lot of gene editing that's being done in tissues right now. You know, it's still pretty new, and certainly the brain is one of the more difficult organs to treat. I think there's a lot of just basic research that we need to do around, you know, making sure that it's safe, because there's no way that any physician is going to do something for a person that would make their disease worse, right? So I think that gene therapy is going to be, you know, if you think about cure, meaning a lasting improvement, then I think that gene-based therapies are going to be lasting in a way that just a medicine, a pill, we all know that there's not going to be a pill that's going to, you know, have a lasting effect. But we should move that horizon further. So no, I don't think personally that 5 or 10 years is reasonable, but I think that we'll be doing the research with that goal in mind.
I echo the sentiment that we really do want to have a lasting change, not just a pill that, and I think that comes, for me, it comes from a couple of different lines of reasoning. One is that we had a lot of hope, and certainly when we started gathering together as a scientific community as well several years ago with you all, I think we had a lot of hope that some of the sort of simple interventions, dextromethorphan, memantine, were going to make a really big difference. And I think what we've seen, at least in a couple of children, is that even if you are able to reduce the seizure numbers, we're actually not making the lasting difference that we had hoped in the cognitive function, in the level of intellectual disability. So I think we have to just be very transparent about that and very honest about that. We had, you know, a lot of hope that these things that were working in the dish and working in animal models would actually then translate to all of the patients who had, for example, GRIN2A, gain of function. And while there's been some modest improvement in seizures, we haven't seen an overall improvement in all of those symptoms that Keith went over that really are important and are life affecting. So I think that's one reason why we have to sort of set our sights on something that could really be disease modifying and have a lasting improvement. But I share Dr. Ramsey's feeling that we're not really at the tip yet of disease modifying therapies in the form of gene editing. And the reasons for that, I think, are important to go through. And the safety is still being worked out. There have been some isolated cases at a couple of our institutions where there has been, for example, a injection into the spinal fluid of something that would change the way that a gene is actually being processed, and maybe making more, maybe making less of a gene product. And there's, you know, there's not really still an answer as to whether that worked, because it's been done in a couple of cases where these were degenerative processes where the kids were losing skills, and they maybe lost skills a little bit more slowly than they would have, or maybe not, and we will never really know because it was not a controlled trial. There is a trial now for SCN1A, which is an epilepsy prominent neurodevelopmental disorder, and that's being started. It's actually already been started at a number of sites, and that holds some promise, both in terms of looking at safety, which is really the object for the next 2 to 3 years from what I hear from the people running it. And then in 3 years, there'll be an efficacy trial, meaning a real trial to see whether the approach even works. So even for that gene, which is one that's been characterized over 20 years ago, where there's a lot of models, a lot of research that's gone on for over 2 decades, we're just seeing the beginning of the first safety trial. I think what's good about that is that we can then at least take the generalizable safety data across many different genes, so to all of the GRINs and others, and we'll see. I think nobody wants to rush in without knowing the safety data. This is a condition where the SCN1A condition where there's a 1 in 5 risk of death by age 20. So there was some justification in that disorder to say, you know what, we have epilepsy as a defining feature. SUDEP is really, really, really common, more than the 1 in 1,000 or so you hear about in the general population, which is already too much. So the risk benefit there was actually a little bit different than in the GRIN disorders, but we'll be able to learn from that experience about safety. And I think from that trial and the Angelman syndrome trial, we'll be able to see whether, you know, at age 4 or 6 or 12 or 14 or whatever age, if you implement some of these treatments that are pretty extensive and involve injections into the spinal fluid, and they're not risk-free, can you intervene late, because it's always going to be late, and have an effect? And so those are 2 ongoing trials that I think we need to keep our ears to the ground about and follow those progresses to see how or if we want to bring them over to this GRIN, the set of disorders.
Perfect. Thank you both. So our next question is related to GRIN 1, and I figure I'll direct that to Dr. Lemke because I know he's working on a review related to GRIN 1. So this particular person was asking about what do we see for gain of function variants generally for GRIN 1 patients? How significant do you believe the functional variants are in terms of drug development and phenotype?
We don't yet really know the difference for gain of function versus loss of function phenotypes for GRIN 1. We are just currently collecting data on this and collecting patient data to be able to differentiate the phenotypes. We know from GRIN 2A, where we have done a comprehensive and larger study on I think it was about 250 individuals, and about 100 of them we had intensive phenotypic data. There we were able to see that loss of function variants were associated with milder phenotypes than gain of function variants. And I believe, but I don't know yet, that this may be similar for GRIN 2B and for GRIN 1 as well. So that's a hypothesis, and we would like to check. And for this, we need more data, more patients, especially GRIN 1 patients or GRIN 1 families, to register in our registry. And regarding treatment, yes, I believe there will be a difference, because it looks like there are some pathomechanistic differences on whether the NMDA receptor is stimulated and working stronger or more than it should, or is somehow blocked. So the one way you would want to apply a blocker to the NMDA receptor, the other way you would like to apply a stimulator to the receptor, and maybe that's a way for an improvement and for a cure. But also this, we don't know yet. That's also a hypothesis.
Great, thank you for that. So our next question is about second generation memantine type drugs. And the question is, has there been any further research into the use of existing drugs for possible treatment of GRIN?
I'm not aware. So second generation memantine type drugs, does that mean drugs that are targeting that specific area of the receptor where the memantine, I'm not sure what that means. So I'm not familiar with that research. I know that there are, so for example, many of you know Steve Trainellis. I know that he's developed a lot of compounds, and he's working with people who make the mouse models to test some of those new compounds on mice. But I don't believe those studies have been published yet. So I think it's early on, the studies in mice to try new drugs. I don't think there's much published.
I absolutely agree to this. There's not even much published on memantine. So I also am not really familiar what is meant by second, what is it called, second generation memantine or something like that. So even for memantine, there's very, very scarce reports on treating GRIN children or GRIN patients with this compound. And unfortunately, for many of those reports, for many of those very few reports, the evidence for memantine is not very good, because sometimes the variant of the patient where memantine has been applied to is not convincingly. So actually, it has not really been a true GRIN disorder, I would say. And for the few where the variant is convincing, the data was not convincing on whether it really helped or improved the situation. So we are still at a situation where we think memantine may be useful, but we do not yet have the proof. And we would need that, and we would need data. And for this, I also can only encourage to register in the registry, and to especially get in contact with Tim Benke, because Tim Benke in Colorado especially collects data on patients that have been treated with NMDA-specific drugs, such as memantine, to learn on how much these patients have benefited or have not benefited, and what possible side effects they may have developed. So we need this data, and I think there will be many patients around that have been treated somehow at some doses by their doctors, and we need to collect this data. We would need a standardized trial, which is very difficult to set up, but that would be the perfect answer. But until we have this, it would be good to just collect all the data that is around. And for this, I just can encourage to contact Tim Benke.
I think by second generation drugs, they just mean, a lot of pharmaceutical companies take the same target, the same drug, tweak it, try to make it more specific, less side effects, or more potent. And I think memantine and some of these other drugs have been around so long that if there was a great second gen that was being studied, we would have heard about it.
Perfect. Thanks, everyone. So our next question is about lysine, and the person says that lysine has been mentioned as possibly helping GRIN2B loss of function. Are there other supplements for loss of function where there's no seizures involved?
I haven't heard about lysine, but they might be thinking about serine. So I know that L-serine is being studied in a clinical trial that's based in Barcelona, but there's participants who are in other countries in Europe. And the trial design is one where there's not really a placebo control. So the results are not out. I think it's still underway. But there has been an N of 1 study that was published where there were benefits that were seen in a GRIN2B loss of function patient. We started giving mice L-serine in their diet just to kind of try and copy what was being done in the clinical trial. And we are getting some preliminary data that it looks like it's not affecting what I would call dopamine mediated behavior. So this would be like activity, arousal state, but it does seem to be improving very modestly some cognitive, like working memory, and problem solving tasks that the animal does. So this is not a slam dunk. It's a modest improvement that we see in the mice. And this is where we have the ability to do a placebo control. So you have mice that get normal diet and the mice that get the diet plus the serine. It's an improvement, and we can even say it's statistically significant, but in terms of being a life-changing treatment, I don't think that's going to, I mean, that doesn't look like what's happening in the mice so far. But I mean, I think it seems to be relatively safe. So we'll put that data together, and when we get more animals and more results, and we will put that out there to publish it. That's all I know about it.
Great, thanks, Dr. Ramsey. So our next question is related to CRISPR. What are the experts' opinions as to when they actually hope CRISPR technology can be developed and tested, and how would a child be placed on a list for testing?
I think this relates a little bit to the first question about gene-based therapy. You know, we're using CRISPR technology in the labs now to generate changes, or if you've got cells that have a given variant, for example, you can actually correct that variant. So that works okay in cells, works in patient cells. We can do these things in cells in culture, so literally plastic containers that have the cells growing and sticking to the bottom of them. Very different from children, obviously. We are using it in my lab in zebrafish and other labs in mice to generate mutant animal models. So we can actually use it as a tool to make these variants and to study them. But in terms of then creating a tool like that, or creating a model and then going in and trying to fix it, we're certainly not there yet in the whole animal model area yet. I think that is, again, on the horizon, but I agree very much with Dr. Ramsey's assessment with that creating the tools, creating the animal models, it's happening, it's working. The safety bar there is very low because you can tolerate things happening in these animal models with appropriate safety and sort of appropriate guidelines and so on being implemented. But we haven't really gotten to that sort of gene editing in children for disease, specifically in the genetic epilepsies. There's obviously a lot of, there's some ethical concerns about gene editing in embryos, of course, but also some serious safety concerns about gene editing in people, given that, you know, CRISPR is something that basically we try to target a specific change. So if you've got let's say a GRIN2A change, which we want to target just that very change and just switch that very nucleotide, that A, T, C, or G, that's not what it should be. But you're putting in a bunch of machinery into cells, and you're basically sort of pointing on a map saying, hey, go here. But there may be other places on the map that look similar and might get off target affected. So we hope for a specific target, but we know from the lab that it's not exactly as specific as that all the time. And so there are some major hurdles to overcome in the lab setting to be able to convince ourselves that it's going to be effective potentially, but also that it could be safely done without having other damage in other systems. The last thing you'd want to do is go in to correct a change in a GRIN2A gene or a GRIN2D or any of the GRIN genes, so that you'd have a positive effect on the nervous system and then have sort of collateral damage in some other system, maybe even in another gene. So I think those are in broad strokes some of the concerns that have to be worked out.
Great, thank you, Dr. Paduri. So our next question is related to the ketogenic diet. What is the ketogenic diet and how can it help GRIN patients?
Anne, is it okay if I talk about this? And then maybe you should talk about it too as a clinician. So the ketogenic diet is a diet that forces your body to create fatty acids as an energy source, because you're not taking in a lot of sugar, which is a lot of glucose, sugar, carbohydrates that would be normally the energy source that your brain would use. So when you're in a starvation diet or when you're in a diet that doesn't have sugar, then your body can create energy for the brain using using fats as the source of the energy. And this was discovered, it was discovered that it helped with epilepsy, first in situations of starvation. And then they developed a diet where you could, of course, continue to survive, but you would get the same effect where there was no sugar, no carbohydrate being consumed. It's not, it's not what we would call a balanced diet, and it needs a lot of, you would need a nutritionist to help achieve this, but it's been known that this helps in many forms of childhood epilepsy, and there are some grandparents who have tried this and found that it helped not just with seizures, but also with some of their kind of developmental progress and gaining weight. So I think that it is something that your neurologist might suggest if a child has, if your child has seizures, they might say this is one strategy, but it's hard to implement in some cases, and some parents don't want to do it because they're worried about, there not being enough fruits and kind of fiber sources and things like this. But I think that if you have a lot of seizures, then it's something to be considered. We have been testing this in mice, and we are seeing benefits in some cognitive domains, and we're actually now going back and trying to see how it affects seizures. So in mice, it's much easier to measure kind of cognition than it is to measure brain seizure activity, because we don't have nice EEG machines. We have to implant the electrodes into the mouse's skull. So we're doing that now, but what I would say is that the ketogenic diet certainly improves some cognitive domains. Again, it's probably more effective than the L-serine treatment, but it's not going to revolutionize their cognition. It's a modest but real improvement.
Yeah, and I'll just echo that it has the word diet in it. So patients sometimes do come thinking it's going to be sort of a more natural sort of therapy, but there's nothing natural about this diet. It's, upwards of 90+% of your intake is fat based, and then the very little bit left over protein and glucose. And so it can be hard. Now for kids who are fed formula, or kids who are fed by G-tube, the taste part is not a problem. For kids who are orally fed, eating eggs with cream and really very little with sugar, it can be a hard diet to take. That being said, if you've been through a series of meds and they haven't worked effectively, it's the top of our list of non-meds to try, frankly, because in some kids it can be very effective. What I hope we might see is actually from some of your mice, for example, that if there are certain genetic epilepsies, if it's the gain of function GRINs versus the loss of function GRINs versus the GRIAs at some point, it would be great to see if there's a different response. I think that would be actually quite helpful and might point us towards, wow, in this group of families, this is something to push higher up on the list. That hasn't happened yet outside of the realm of, there's a gene called SLC2A1, completely separate from GRIN. And kids with that disorder and adults with that disorder, they can't get sugar from their bloodstream into their brains. And so they don't have the fuel that they need to efficiently have their brain work. They have to have the fats as the source. So that's the situation where, wow, that's the fit that actually specifically addresses their biological problem. It wouldn't be that for any of the GRINs, but it might be that some of the GRINs respond differently. And the reason I say that is, particularly for the GRIAs, the ketogenic diet sort of approximates some of the effects of topiramate or Topamax and zonisamide, Zonegran, and we always think of some of the simple effects that it kind of copies. It changes your blood acid-base balance, but there may be some other things that are similar about the diet and those meds that are particularly responsive to one versus the other, and that some receptors might respond to. So I feel like it'd be nice to see what the mice show, if that might guide us, because I think it'll take otherwise a long time to see dozens of kids on the keto diet with each set of conditions to see if there's really a difference.
Thank you for that suggestion. I will do that.
And we also had a follow-up question in the chat about it. What about keto in infants with epilepsy? So would the recommendation be any different for infants?
It can be done. It's a delicate start. We usually have patients, and I trained at CHOP for my neurology. I've been at Boston Children's for many years. We have very, very similar approaches in our diet program. And I think most of the epilepsy centers or pediatric epilepsy centers in the US have a ketogenic diet program. And it's a physician, nurse, dietitian team. And they have to do a lot of pre-screening for safety to see if the child will tolerate it biochemically. And they'll admit the child to the hospital for several days as their body's chemistry is changing on it. And so there's a lot of risks of low sugar, risk of becoming too acidotic that you have to balance. And so for that reason, we originally shied away from giving this diet to very young infants, but it can be done. Usually it's reserved for when other things are not working or more conventional treatments aren't working, but it certainly can be done in the right setting with the right safeguards.
Great. We have another question related to a different type of diet. Can gluten have a breakthrough on the NMDA receptor? So the person describes their child's development and suggests that they started a gluten-free diet prior to the diagnosis of a GRIN2B variant. And they said that the diet was carried out for celiac disease, but there was a negative result. Any thoughts on the effects of gluten on the NMDA receptor?
I will say, because I'm on a strict gluten-free diet because I also have celiac disease, that I've thought about it a lot, sort of on the side for my neuroscience world. I've tried to look into this aspect of science as well for the same reasons that you all are here thinking about the NMDA and AMPA receptors. And I can't necessarily connect the dots there in a way that makes sense, but there's a lot we don't know. I mean, in the same way that there's a lot we don't know about how the ketogenic diet works, and it may some of the effects of these diets may not necessarily be only the effects on the biochemistry that we've all learned about in med school and grad school. Some of them may be on the bacteria that are in the gut. So there's a whole microbiome story that's emerging about the ketogenic diet, and specifically some bacteria that might be helpful and that actually might have some effect on seizures. So, is a gluten-free diet potentially affecting the microbiome of the gut? And is that having some downstream effect on overall, energy, the nervous system, and so on? I suppose that's possible. There's no evidence yet, but it's certainly something that, that's something we might figure out in the next 5 to 10 years, because there's been a huge, very, very sudden and large amount of interest, including at the NIH and other organizations, to try to understand, what this all means, because we really kind of, when I was in med school, we didn't even talk about a microbiome. The word didn't exist. I don't think it wasn't something that was on our radar. So I think that's as far as I would go with the diet.
Perfect. So our next question is related to GRIN2B and schizophrenia. And so the question is, based on the available data, how common is it? And does it look like a classical case of schizophrenia? If anyone has any experience with that, as well as they note that their child has recently been prescribed risperidone and pipamperon. And if you guys have any experience concerning those types of medications with GRIN2B patients.
Psychiatric disorders, for example, schizophrenia, can be associated with GRIN disorders, mostly, as far as I'm aware of, with GRIN2A related disorders. And this may be mostly due to the fact that GRIN1 and GRIN2B individuals are usually more severely affected, and children that have a more severe developmental delay and intellectual disability, they can be sometimes more difficult to be diagnosed with psychiatric disorders. However, for GRIN2A, it looks like there may be some sort of association. And in this question, this parent asked for a splice variant in GRIN2B, which presumably may be a somewhat milder phenotype than the usual, let's say, gain of function variants. So yes, it may be possible that there is an association. we still cannot really answer how different a GRIN-related schizophrenia will be from a normal schizophrenia. So that's far too early to evaluate. Also, regarding treatment, I don't really know. I would give this question further to a clinician.
And I'll say I haven't actually, in the very small number of patients I manage and my group manages together, we've had mostly younger children. We haven't actually had a case that I'm aware of anyway, among the three of us who work together in epilepsy genetics. I haven't come across pharmacological management of psychosis or schizophrenia.
Not for any GRIN, or just not for GRIN 2B? Anne?
I have not for any GRIN to date.
Okay.
Yeah.
Can I just ask a quick question of Dr. Lemke? So schizophrenia, from what I understand, it would involve multiple genes. So it would, is that right? So it would typically be a variant in the GRIN 2A gene, but also involve other genes, or could it be just one gene that causes it?
That's a good question to which we have no answer yet. Schizophrenia is actually not considered as a monogenic genetic disease. So you would not expect that a patient will have one genetic variant, as for example, a mutation in GRIN 2A, that is causative for a psychiatric disease. But somehow, at least for certain variants in GRIN 2A, it looks like that these variants predispose to psychiatric disorders such as schizophrenia, but we don't know why schizophrenia occurs in a fraction of these patients, but does not occur in others. And even in families with a rather mild phenotype, where the variant has been inherited and transmitted to several family members, some may have additional psychiatric disorders and some may not. So even within a family, there may be differences. So it looks like there will be other possibly genetic influences that modify the risk of developing schizophrenia. So we don't know yet. It's most likely not a clear monogenic disorder.
Yeah, I would agree. I mean, from a clinical perspective, I would also say, when we think of schizophrenia as a broad group, it's typically onset in the teens or early adulthood, and not necessarily in the setting of a neurodevelopmental disorder. So the studies that have been done that identified these polygenic risks, where lots of small changes in many genes, for example, as Keith, you mentioned, those are somewhat in a different context. I mean, those were largely done on people who had schizophrenia, and that's their primary diagnosis. We are seeing several similar symptoms, so psychosis and extreme behavioral dysregulation that might actually be considered the symptoms of schizophrenia in patients with a whole host of genetic and still undiagnosed neurodevelopmental disorders. Specifically PCDH19, it's quite prominent. I've recently heard of a couple of cases with KCNQ2 variants where the typical drugs that are used, as are mentioned in the chat, the risperidone, those sorts of dopamine-acting drugs, have resulted in some pretty prominent side effects. So I think when we talk about schizophrenia and psychosis in the context of kids with a GRIN disorder, it's maybe a little bit different than the classic schizophrenia with nothing else going on. And I think, certainly from my perspective, seeing mostly young kids and really from an epilepsy lens, I haven't seen enough. I think it's not that they're not there, but they're not yet diagnosed.
I mean, it's my understanding that it's the new GWAS studies where they made even bigger cohorts around the world, that finally you have these genes pop up to true significance, and one of them's GRIN 2A, one's GRIA 3, which I think is surprising. And then there's a trio, which is the name of another protein, all of which are implicated in neurodevelopmental disorders. So I suppose an interesting question, Anne, would be, are the ones that have a GRIN variant that become schizophrenic, do they show any symptoms younger, or are they distinct classes? Is that kind of what you were saying, that you don't have enough of a data set, or who knows?
Yeah, I think it would be, it's not, and I will say it's not something that as an epileptologist, we're often so focused on the seizure part, and that takes up so much of our attention, that unless we ask, about sleep, or we ask about behavior, we ask about some of these other symptoms, they're not always necessarily brought up right away because we're so focused on the seizures. And I think as time goes on and we kind of reach some stable point with the seizures, as neurologists, we might start to approach the questions, or we might start to see these things develop. But personally, I don't have enough of a local data set to say that it's specifically these genes versus these within the GRINs, because we just haven't seen the kids. I think we haven't seen them get old enough yet. But I would predict that it might be a younger onset than the sort of classic schizophrenia with nothing else going on. But again, we don't know. But I think the treatment is going to be, again, you'd like to modify the disease with something, even if it's a memantine or something that doesn't work completely, you'd like to modify the disease enough that maybe you don't end up with these problems. But if you do end up with these problems, the drugs that we choose and so on might have to be chosen more carefully, given the potential for, again, off-target side effects from the classic psychiatry meds.
Great, thanks all. So our next question is related to anesthesia, and if there are any anesthesia protocols or suggestions to make to the hospital related to GRIN disorder. They note that their child is having dental work and is going to be put under anesthesia.
We've done some stuff in mice. I'm curious to hear what you have to say. Anne, I see that you're going to unmute yourself.
I was going to ask you from the pharmacology perspective what you think.
Okay. So, right. So one of the typical anesthetics that's used in children particularly is ketamine, which would be a tricky one to use for GRIN patients. So the anesthesiologist should know, but I don't know if a dentist would know, that ketamine may work differently in your child because ketamine is directly acting on the NMDA receptor. It has a few other actions. It's not purely acting on the NMDA receptor, but that's a big part of it. So ketamine might be one that they would want to avoid. But if they're using another kind of anesthetic, like an inhaled anesthetic, it is possible that your child could be more sensitive or less sensitive to anesthetics. And we've done some work with mice that are gain of function and loss of function in GRIN1, and it looks like there is a different sensitivity. So it looks like the loss of function are more sensitive. So it takes less, the anesthetic that we used was isoflurane, which is a typical inhaled anesthetic. And we count the number of seconds it takes for them to lose consciousness, to, kind of fall over. And so it happens much faster. The nice thing about those inhaled anesthetics is that they're very easy to control. So the anesthesiologist would be they're always watching, and they, for every person, we all have differences in how we would respond to an anesthetic. So it's just, they would need to know, yes, you need to monitor this. We've also seen that on the other side, the gain of function mouse is less sensitive. So it took even more isoflurane for the gain of function to go under. So it may be that they need more anesthesia than the typical patient. So I would say that it probably, you should let them know, my child has a variant in their GRIN gene, and they may have a different response to anesthesia. So please monitor carefully and, be looking for signs of, distress or pain, and also you would not want to over anesthetize. So yes, I think that probably children with GRIN variants probably will be differently sensitive to anesthetics, and we may see that depending on whether it's gain of function or loss of function, it could be different. So I think it would be interesting to include this on surveys to ask people has your child been anesthetized for a dental procedure or a medical procedure, and did the anesthesiologist report that the child was more sensitive or less sensitive to the drug, and I realized that usually anesthesiologists, they list about 5 different drugs that they use, and it's all a bunch of names that it's hard to keep in mind. So that might be a hard question to answer, but if you have those records and you know exactly what anesthetic was used, I think that could be useful information.
Great. And so our last question from the ones that had been emailed previously is related to hemp products and CBD and THC, and if there could be a wide range of benefits related to seizures, cognitive support, or behavior and mood, and what type of research that about that's going on related to these products.
We've been trying it in mice, and we've been trying with CBD, and so far we haven't seen a lot of improvements with CBD in seizure or in cognition. So we're but you always wonder, did we give the right dose? So we gave the dose that was used for another syndrome, Dravet syndrome, which Dr. Paduri mentioned, the SCN1A. So we used that dose of cannabidiol, and it didn't really seem to do much in the, it was a gain of function variant of GRIN1, but we're just starting with that. I'm not familiar with other research that's been done.
I'm not either, specifically in the GRINs. I mean, I think in general, as with the ketogenic diet and others, these are not necessarily thought to be disease specific. Drugs that are acting in a disease specific way. Now, there may be some specific reason that the sodium channel disorders respond a certain way that we can theorize. It hasn't been really completely figured out. So I think there's the side of us that wants more information and wants to understand it, but I think it's also not unacceptable to say, let's try that just like you would try any other medication. These are all what we call empiric trials, meaning it's a trial and error experience. It's not necessarily going to tell us specifically if your child's variant is going to respond. There's that experiment largely hasn't been done. Could be done, although it would take a long time to do it in the cell. All of the ones that have been characterized, for example, in the Center for Rare Variant Characterization, and all of the models that all of the scientists have looked at, it would be a very, very Herculean effort to sort of do that, and maybe not necessarily time efficient. And so since some of these are drugs that are just available, treatments that are available, it makes sense just to try them as you would another medication for the time being. I sort of say we want the science to happen, but you also have to do something today. And so certainly Epidiolex being the one that's prescribable now, and that's, at least we know how much is in it. Those are the ones that I think as prescribing physicians we feel most comfortable with. If I prescribe 2 mLs of Epidiolex, I know what's in it exactly, and I don't have to worry about what else might be in it as a byproduct. There are several other forms that people can get privately and have to dose according to the guidelines, and I think that's also fine. But I certainly ask people, and I ask my own patients in our practices, let us know, because there certainly can be effects on the levels of other drugs, particularly valproic acid and clobazam and so on, where those levels can go up. So we see, with Epidiolex and CBD products, we do see some improvement in some kids. We see no improvement in some kids, and we see improvement and sedation in some kids, and kind of everything in between. And if that sounds like any other seizure drug, it is like any other seizure drug. So that's important to keep in mind.
In our studies with the mice, we weren't combining it with other anti-seizure medications. So what you mentioned about it, that the cannabidiol might be changing the serum levels of the other anti-seizure medications, that's something that we, haven't tested, but that's that might be why we're not really seeing much effect in the mice.
Great. So we have lots of questions in the chat to get to in our last few minutes. So first, it was a question that Keith had addressed earlier related to panic attacks in GRIN kids. And then someone else asked a question about time-related anxiety and if we know of anything related to anxiety during timed activities in GRIN kids.
I don't think we do. I mean, I know there was a question asking what a panic attack is. It's funny, I was driving home yesterday and there was a whole NPR piece on panic disorder versus panic attack. Not in the context of GRIN disorders, sadly. It's too bad we haven't made it to NPR yet, but it was it's certainly on people's mind given the mental health concerns of the pandemic and various other things that the general population is experiencing. So I won't go into a whole lot of psychiatry, but panic disorder and panic attacks are things that people can have just like schizophrenia without a genetic neurodevelopmental disorder. But the symptoms of panic attacks are really sort of a almost irrational inability to proceed with what one is supposed to be doing in the setting of anxiety. So it's sort of related to an anxiety disorder in a way as well. For these sorts of symptoms, just like the seizures and just like movement disorders and other symptoms, the treatments are really still empiric. So it's still sort of, there's a list of drugs you might use for anxiety. There's a list of drugs that you might use for panic itself. And there may be extreme panic and you might want to use something like an Ativan or Valium, which is something you might use for a seizure cluster. But that's really sort of a one moment in time. I think, if you're thinking about daily medication and your physicians are thinking about, well, you've got thus and so symptoms, let's treat these. Really important to connect back and say, just remember my child has a disorder that's affecting the glutamate system, because it may not be that everybody's going to think of those things. In many settings, it's primary doctors prescribing, and they should know that they can reach out to the network and just ask, does anybody have any experience with these drugs? The answer may be no, in which case we might say, well, cautiously go ahead and try and let us know. But I think it's worth asking, just like with the anesthetics and just really with anything. I would think of the presence of a GRIN or GRIA disorder being a red flag to say, you can't just prescribe anything for my child. It's almost as if, when you have somebody on a clinical trial and you enroll in a clinical trial and it says, if you're going to be having any new medications, make sure your doctor knows that you're on this clinical trial and see what the interactions are. Here in this case, it's not a clinical trial, it's their life, right? They always have this NMDA or AMPA receptor abnormality and this dysfunction. And so that's important to bring up anytime any new medication is brought up.
We have a related question to a different type of drug, to methylphenidate for treating ADHD in GRIN 1. Does this have a chance of worsening the disorder, and what should we be aware of?
Talk about stimulants.
Yeah. So when we were first studying what happens to the brain when GRIN 1 isn't working, but I think the same could be true for GRIN 2A or GRIN 2B in this, that we were looking at changes in the dopamine system, and that's really important in attention and impulsivity and things like this. So we're really not sure exactly what's going on with attention deficit disorder. And so the drugs that are generally used to treat that are drugs that will change the amount of dopamine that is in the synapse and basically increase the amount of dopamine that's in the synapse. We saw different effects depending on the type of drug. So what we saw was that drugs like cocaine and methylphenidate didn't have much effect. So they didn't have a negative effect. They didn't make things worse. But drugs like amphetamine, which would be like Adderall, did make things worse. So it's interesting that even between different medications, we did see a difference there. I don't know what the reason for that is. So, but what I would say is that methylphenidate would probably be better than amphetamine, just based on what we saw with the mice. But I don't know if it would actually improve attention or not. I mean, I guess you would just have to see whether it does or not.
This has been great. Thank you all for all of your feedback. I'm going to end with one last question from Keith about the gender imbalance in our survey, and particularly for Dr. Lemke, do you see this in the database as well in terms of more female report?
I wrote down a note to check earlier, so I don't know, but it's an interesting point and we will check.
Perfect. Thanks so much, everyone. So I believe Denise has put in the chat where we can go to register for the happy hour. So if you haven't registered yet, you can hop on and register. I want to thank all of our panelists for their participation and for answering all of your questions today. And we'll try to capture any questions that were in the chat that we weren't able to ask, and perhaps try to get those out to everyone.
Thank you, Megan, and thank you everybody for joining us. I just wanted to say thank you to Rafael Gonzalez for the amazing video that we shared this morning right before we started the session. We might try and share it again here if we have a moment. But right now we're going to hop over to our happy hour session. I put the link in the chat. If you have not registered, please go ahead and register and join us over in the happy hour. Thank you again, everybody. It was an amazing session.
Just one thing to note, if you're joining the happy hour, in sessions where we've done this before, some people have had problems because they've left the Zoom open and the Zoom's been controlling the camera and mic. So if you're joining once, you probably want to shut down your Zoom. Thanks, everyone.
Thank you.
Thanks, Denise. Thank you so much. I've learned a lot from the questions.
Thank you for joining us.
I actually jotted down the male-female imbalance as well too, just to see if, just locally, and we can ask Tim what he's seeing. It's but that's curious, and doesn't seem like it's just it's 2/3. It's not 51, 49. It seems like a lot.
Yeah.
Thank you. Okay.
Thank you all. Hopefully we'll see many of you in the social gathering.